Welcome. Episode number 10 of True Health. Somebody's with me here.
Hello.
Can't see the video. So this is an episode of Beau Beards.
Da beards.
That's good enough. Maybe I'll put a little audio tag in there. So today we're covering viewer Q&A on Diastasis Recti.
Say what?
Diastasis Recti. I don't care which emphasis you put on which syllable. I know people got their semantical issues. But that comes from, I'm going to look her name up real quick. It's Michelle. She's a yogi. I'm going to butcher her last name. Just she knows who she is. Hey there. So thank you for the question. As always, I appreciate it. Keep sending your questions in. We've been getting some good feedback and comments on the YouTube channel. Today, we're not getting too technical with the video aspect. So I'm trying to push people more to the audio side of things because they've been a little bit longer in format. Today will be a little bit shorter. So if you haven't checked out the podcast on iTunes, make sure you go over there, download it so you can listen to it in your car. My voice, I've been told, sounds like
a mix between
a sleepy
Jesus and Fergie.
Yeah. I was gonna say a mix between like a sleepy time tea, brandy with a little bit of cinnamon. It's just super smooth.
Oh, so they listen to this before bedtime?
Maybe.
Okay.
Yeah, so subconsciously they just get smarter as they fall asleep.
It's like when you read me stories before bed.
But little do they realize when they fall asleep, I'm whispering things to go buy my webinar and other sales tactics. All right, let's get rid of the tomfoolery here. So Diastasis Recti, I'm sure a lot of people have heard about this. There are entire websites that are dedicated to this. There's actually diastatisrecti.com. I wish I would have had that one. I would have sold it.
Yeah.
Right now, a website I'm trying to get
is
being held ransom, and I'm trying to get it. That's what a good website would be, websiteransom.com.
I bet you that exists.
Check it out for me.
I will.
Okay. So what is Diastasis Recti? If you've ever seen it, you know. It's basically where you get a protrusion of the abdominal wall via what's called the linea alba. So that would be the line in between your six-pack. So the clinical definition is the protrusion has to be greater than 2 centimeters. There's a technique super technical technique where they use the width of your finger. So if it's 1 finger, 2 finger, 3 finger, 4 finger, but 2 centimeters or greater to be an actual diastasis recti. Otherwise, it's probably just a little ventral. It's a form of a hernia, if you want to call it that. But it's basically a strain or a thinning of that linea alba. Linea alba is, it's called that, first of all, because it is a white, basically myofascial structure, very tough structure. Obviously, it's holding help in the contents of your abdominal wall. But when we see people with pregnancy or obesity and things like that, and we're going to talk about the specifics of why it occurs, you see this strain occur. But that's basically what it is. And you've probably seen it. You typically see it if somebody tries to perform like a sit-up or if they try to get up from laying flat on their back to sitting, you'll see a protrusion. Now, that is different than an umbilical hernia. An umbilical hernia, if you don't know what your umbilicus is, which, again, what are these semantics? Do you remember in school people would
skeletal.
Skeletal? Well, that's a little if you hop the pond, but umbilicus is your belly button. An umbilical hernia is where you get a protrusion over your belly button. You went from an innie to an outie or a little outie to a big outie. So there are all sorts of causes. Like I said, it's a strain or a thinning of that linea alba. It comes from some sort of a loss of stability or no stability to begin with. And that's what I want to start with is the little guys and gals that this happens to. So when a baby is born, there are rectus abdominis. Well, let's go over some anatomy first. So from outside to in, if you're looking, just imagine your G.I. Joe or kin abs, right? My six-pack, my rectus abdominis is the most superficial layer. The role of that muscle, a lot of people think it is to flex your torso. It's probably more so anti-extension to help not excessively or, I don't know, what would be another way? To just help control extension, right?
Yeah.
So that's your rectus abdominis. Then the next layer would be your external obliques. Your external obliques, if you put your hands on your side up by the top of your rib cage, That external oblique goes down towards the opposite side hip pockets, right? So that's the next layer. External oblique is also called the mother oblique. From a germ layer or basically a developmental standpoint, as you grow, the internal oblique comes out of the external oblique as we develop in the uterus. So then we have our internal oblique. So if I gave myself a hug with my fingers pointing down, that's what your internal oblique would be doing for anybody that's listening. So it's going down towards the same side pocket that my hand's on if I cross my arms over my abdomen. And then the bottom layer of our big kind of three muscles would be our transverse abdominis. A lot of people call that the Pilates muscle because that's what's famous for the suck your belly button into your spine. And a lot of that research that came out of Australia probably 30 years ago that talked about transverse abdominis and spinal stability. We'll talk about that in the rehab section of this. But that's those three layers. That linea alba is right under the layer of your basically rectus abdominis. And if I start to lose stability for, like we said, various reasons, pregnancy, overweight, something like that, it starts to strain. So kids, when we're born, that rectus abdominis, that top layer, is not fully closed. And that's not a dysfunction. That's just normal because babies have not started to go through the developmental sequence, right? And that's called developmental kinesiology, how we move, that is predicated by that's still kind of up in there. How is that happening? You know, is it genetic code, whatever it is. But a few positions that start to develop that is when a baby is on its back. And when a baby is about 3 months old, they can basically bring their knees right above hip line with their lower legs bent. At about 5 months, they can start to bring both feet together. At about 6 to 7 months, they can start bringing their feet up to their hands, and then you see 7 to 8 months, they can put their toes in their mouth, right? And a lot of people, that's happy baby in yoga. It takes a lot of lumbar and torso flexion to make that occur, especially in the lower abdominal wall. And that's how we start to close that kind of, or bring your rectus abdominis closer together. But some kids skip that step, right? We didn't spend enough time on our back, or we didn't go through the proper developmental sequence, or we had what's called a central coordination disorder. And I'm going to be linking an article talking about central coordination disorders, and I'll just throw this stat out there. 30% of children that had a diastasis recti from birth, and it never closed around that kind of 3 to 6 month mark, it's just going to be, you know, somewhere in there. 30% of those kids had a confirmed central coordination disorder. So now we need to define what a central coordination disorder is. It's basically, I hate to say a sensory processing disorder. It's more, it could be processing, it could be integration, it could be a true lesion, right? We have something that's actually wrong with the hardware in, you know, the cortex or the cerebellum or the spinal cord. So your furthest end, the most drastic on the spectrum would be something like cerebral palsy, right? And we know the classical like movements of a cerebral palsy patient. You know, the knees kind of cave in, we're up on our toes, the arms kind of roll into internal rotation. We call it a very primary position, right? We're rolled into home or like a fetal position. Your lowest end spectrum would be any of the things that we consider like spectral disorders, right? So anything from autism, ADHD, sensory processing disorders, basically where kids are either having problems bringing information in from the outside, passing it through the spinal cord, the cerebellum, and then it manifests, and it could be speech, it could be movement. Normally in here we're talking and looking at movement, but like I had a 6-year-old patient yesterday that there were speech processing things, there were some attention issues, some focus issues, some behavioral issues. The movement was actually the lowest on the totem pole. Right, but they're all in the same spectrum, so that's a good thing to know. So what's the link there? Well, like I said, if a baby or a newborn is starting to skip some steps or doesn't get enough stimulus, right? And here's a little tip I'll throw out there in between here. So when we're talking about setting up our nursery, right? So if you're expecting, and a very common thing for crib placement is to put it in kind of the corner of the room, right? Which means we usually have one entire corner that's up against a wall. If you have to do that, which is going to be dictated by obviously your house and the room that you put the nursery in. If you do that, we need to make sure that every time we put the baby in there, we're putting them in opposite direction. So head is in there one way one time and then head the other way. That way, if we put them always in the same head-to-toe position and there's the one corner of the wall, let's say that's always on their left side, that means all the stimulus is coming from their right side. So they're going to start to roll over that right side more often. They may not roll over the left at all. When we put them on their stomach, they may only have good cervical and thoracic rotation to the left, because that would be where they'd be looking if that was out over that side. So I'm not telling you to put your crib right in the middle of the room, but that would probably be ideal, right? Then we also want to think about like window placement and things like that. Where are the biggest points of stimulus in the room coming from? Obviously, the door where people are coming in and out. We think of a mobile that goes right over top of the crib, which is pretty easy. That's pretty neutral as far as the input direction. But then we can play around with where we put toys in the crib if we see that your little one's only rolling over one side, right? We may put the toys on the other side and just kind of, I hate to say train them, but that's kind of what we're doing. So it could come from environment, right? So it's not this necessarily a central coordination disorder that's a lesion, like we said, but it's environment. So the stimulus was altered, which then altered movement. We skipped a step, we could end up with this diastasis recti. It could be truly a matter of my cortical development is lacking, right? There's something going on there. We don't know if it's genetic. We don't know, is it lack of oxygen at birth, which is what cerebral palsy would result in. And now I have problems stabilizing around my midline, and that means I have problems with the closure of that rectus abdominis. Lo and behold, I hang on. I have that diastasis recti. Okay, and there are a lot of reasons in between and variables, but that's going to be your big ones. And again, if you see your kid beyond let's say beyond 7 to 8 months for sure, if they go into a sit-up position, lift their head up off the bed or the floor from a supine or laying on their back position, and you see that ridge occur right in the middle of that line, there are all sorts of rehab techniques out there. We're going to talk about some of them that we want to start employing. Hard to do with a 7 or 8 month old, but there are definitely things we can do. So that's the little ones. Now let's go to the most common category is pregnant or postpartum women. So the stat on this is about 45% of women will experience diastasis recti abdominis, which is the term, or DRA, during or after pregnancy.
I'm going to interrupt and say I found a stat that says it's 100% of women after the 35th week will have diastasis present, but it may not be affecting them. And
this comes down not to semantics, but definition, right?
Measurements.
Because we said it is a strain thinning of the linea alba, so you don't necessarily need protrusion, right? So the prominence or the
thinning of
persistence of a diastasis recti after. But yeah, this actually study that I looked at, I averaged it. So it looked at 4 stages during pregnancy. Mm-hmm. So basically probably, I don't know what weeks there were, but it went from like 35% all the way up to 65%, which is obviously later in pregnancy. Mm-hmm. There are things that we could probably be doing. So anything that I'm going to talk about in the rehab portion would be great prehab. And if I'm trying to get pregnant, or the first 3 months of pregnancy, to start offsetting this stuff, right? Because you're going to see people that have a more intact pelvic floor and good pelvic girdle and good abdominal bracing strategy probably have far less, I don't know if that's been studied too much, far less prevalence of prolonged DRA after pregnancy or during. Mm-hmm. So about 45% are going to deal with it to where it's an issue. Now, with that, there's a little bit higher prevalence, and this goes back to birth defect, DRA. There's a higher prevalence in African Americans overall. It really wasn't discussed why. That was just the finding. And in this study, there were 390 some participants. So I don't know if that's a collagen makeup thing or what it is, but that was just a higher prevalence. Let's see. So in men also get this.
Which surprised me when we started practice, because you always think only women, only postpartum. And even though I see a good percentage of my patients as postpartum, like moms, new moms, I see it so much in men.
Which is funny when you
blows
look
me away.
In the literature, there's not many stats on men. I couldn't find a percentage on, how many men which then the question is this something that developed later in life, or have they had it their entire life, right? We're hanging on, which I would say most of them have had it their entire life.
Most of my men that I'm seeing it on have are a little bit overweight.
Central adiposity, which is one of the,
That's a very nice way to say
correlative factors, right? They're a little bit overweight, which
or
just
they
like
previously
pregnancy,
were.
yeah, puts strain on the abdominal wall. We don't have a good bracing strategy. There we go. We have that strain on that linea alba. I couldn't find stats. Just something, obviously, we just said it's tied to obesity. Another thing that they found correlated, not causative, one way or the other, chicken or egg, is a abdominal aortic aneurysm, right? Ooh. Now, if you think logically, why? If I have a poor bracing strategy and I start to move the contents of my abdominal wall forward, I put a little bit of strain on the endothelial wall of the artery. Obviously, that's going to change the flow rate, the turbulence, especially against the anterior portion of that wall, and that's where aneurysm, before it has basically dissected or burst, is going to be equivalated to an egg on a tire before it's about ready to blow, right?
Also think of the lifestyle factors that may lead into both of those.
100%, yeah. If you're overweight, you're probably not taking care of your diet, and your diet can help lead to that stuff.
I'd also look at collagen makeup. You know, if there's a weakening of your vessel lining versus a weakening of your fascia.
Yeah, which I would always like to, obviously there's always endless studies you could do, but to see if people, you know, with hypermobility, do they have a higher prevalence of this during birth? Redheads, we know that redheads have, it's not a collagen defect, it's just a genetic collagen makeup thing. They are often more flexible, more prone to hypermobility, more prone to things like migraines, right? And that's just so, I don't know if those stats are out there or not, but when I dug in, I didn't really look at that redhead correlation too.
The feminist in me also wants to point out that we get very stereotypical in research. You know, we research women with diastasis recti because of pregnancy. I think that's probably another reason why it's lacking in the male realm.
But I think a reason that it should be studied across the board, which there are some studies out there, we need to kind of move into, like, what's it mean if you have this thing, right? We talked about what it is, the prevalence, who's going to have this issue. So what it means is basically just like you would think. If I have a protrusion, think of it like somewhat of a hernia of the anterior abdominal wall. This is the chicken and egg discussion. Did I have a lack of stability that led to this? Or is it the fact that now I have that issue that I have a lack of stability? I think it's probably always both. Pregnancy may be the one different factor, right? I didn't have any issue before. Maybe I had triplets, and now I have a diastasis recti, and now I'm more predisposed to things like lower back pain, incontinence, absolutely, and we'll talk about all these why. But then also overall stability issues. You see, which again, I'm going to put a link to a study where they saw overall stability, which how you test stability, you know, is maybe that's here nor there, but even in shoulders and hips, right? So we had a lack of stability, which you could use like an inline test or an overhead test, something like that. So you're just seeing, which we know from the functional, you know, rehab and movement world, that if I lack midline stability, I'm going to lack distal stability as well. I mean, that just should make sense to most people. So we were talking about incontinence. So let's start talking about how this affects things from the actual mechanical standpoint. So if I have this kind of protrusion forward in my abdomen, let's think again what I would have to overuse to get up off the ground. Let's just start there. Right? So if my rectus abdominis can't work quite like it would before, you're probably going to start to default things like TFL, right? Like superficial hip flexors. You're going to see a very heavy use. You have the anterior neck, SCMs. A lot of people would say like your SCMs and your scalenes are kind of a mirror image of your obliques. Yeah, and you're going to see these people manifest with compensatory stability strategies like clenching of the jaw, leads to TMJ pain. You'd be like, man, you're creating a huge narrative of how these things are connected. But just think of somebody who is grossly unstable and just what they do to compensate, right? And we're just saying this is a predisposing factor that's correlated. It does not cause these things. There's just prevalence, a higher prevalence of back pain and instability issues with this. And again, I don't know if it's chicken or egg or is it just a little bit of both. Now let's say I'm just standing or walking, right, or running, and I have this issue. Obviously, if just think of it like your guts are trying to come out through the middle of your abs. If that's happening, you're putting excessive posterior to anterior strain on your spine, right? It's literally being pulled into a hyperextended position, which means that the posterior elements of your spine, your PLL, the dura, all these things are having to maintain a low level, basically passive insufficiency, right? They're going to be maxed out, which can lead to things like facet irritation. You can still have disc issues, even though it's an extended position. And then it's harder to recruit things like maybe the posterior chain when I'm in such that anterior tilted position, which, maybe that's not completely true, but just tip your pelvis forward like you're in a J-Lo posture and then try to squeeze your glutes a little harder than if you were in a neutral pelvic position, right? And then you get into pelvic floor, right? So there are separate issues that come from postpartum, non-rehab scenarios, which I think should be talked about at some point. But if I have a diastasis recti now, let's just talk about the birth trauma. A giant little human went through my birth canal, right? So it passed through all of the musculature of my pelvic floor.
Totally worth it, but complete destruction.
So I've had some trauma that probably needs to be rehabbed, right? And now let's say I have an anterior kind of instability, and to compensate, I'm just locking up my low back. Well, assuredly, I'm going to give up ground to save my spine, and sometimes giving up ground means I give up a little P2 when I do things like jump rope or box jumps or run. So you see a lot of that go hand in hand, and where I would start, which we'll start going into the fix or the treatment options, where I would start with most people with this would not be like, ooh, we got to get your rectus abdominis closed. It's like, hey, build the foundation upon which your entire abdominal girdle needs to work, which that starts with pelvic floor, right? And your pelvic floor is not just the muscles at the bottom of your pelvis, on the anterior portion, the lateral, and the posterior parts. So a quick anatomy lesson for the pelvic floor. There's about 6 muscles on the bottom of your floor. Think of those in most of ischio-coccygeus, pubococcygeus, levator ani. Then we move into the posterior section. We have piriformis. We have, what do we got? We got one other. We got obturator internus. What else we got? Help me out. There's one more posterior element just inferior to piriformis. What's the next muscle down? I'm blanking. Man, I need better anatomy lessons here. But anyways, you kind of have a bowl of musculature, right? And then on top of that bowl, the ceiling of the bowl would be your diaphragm, right? The anterior portion would be all of those muscles that we talked about. Coccygeus, yeah. And then the posterior part would be obviously your spine, the passive elements that we talked about, but then also the deep layer of the erector system, right? So I always go back to what was the acronym for our spinal erectors? Do you remember, Sloan?
No, I don't.
Spinal muscles rock. So the deep, right? So the deep are the little guys, right? But there's also our thoracolumbar fascia that is deep that kind of helps stabilize the posterior elements there. So those deep ones are the tiny spinal, probably maybe more proprioceptive muscles, but those proprioceptive muscles are getting overloaded in this scenario, like your rotatories, your multifidus, and the spinalis. No, spinalis is wrong.
Just rotatories, multifidi.
Okay. So there's our build from an anatomy standpoint. So what's happening here is really my rectus abdominis cannot do its job because it has a strain through basically the middle, right? I've stretched this out. So this is where you get into maybe differing theories on how to rehab this. I think a lot of people, old school rehab, would say transverse abdominis activation, right? Hollow your abdomen, because transverse abdominis does help close that kind of distance down, right? But here's the thing. That is not a long-term or what we call low-threshold stability strategy.
That's the same thought as doing Kegels
100%.
For the pelvic floor.
It's also the same thought as, man, my glute is really tight, so I'm going to it's probably tight because it needs to be stretched, so I'm going to go stretch it, but it never becomes untight. Probably because it's stuck in that concentric load because you lack stability, right? It's tight for a reason. So the last thing I want to do is take the thing that may be working pretty well, make it do more work, and still not be able to use the thing that can't do its job. So again, we got to start with pelvic floor. So this is not Kegel-based work, right? If anything, you're probably in a massive Kegel if you have a diastasis recti. You're in a kind of a squeezed or contracted position down there to help hold on to the contents of your pelvic floor to give you a little bit of stability. But I've talked about this before on the show. Now we need the ability of that pelvic floor to accept a kind of stretch, or we would call it kind of creating a bigger basement for the pelvic floor. So the best position for that, which used to be the most common position for birthing, is a deep squat, right? Now, let's say we're limited in a deep squat. That's an issue, right? And we'll talk about that in a second. But if I can get into a deep squat, maybe I got to hang on to something like a door frame or a TRX or something like that. And if I can just start to breathe down into my pelvis like that, that means that pelvic floor is starting to have to create an eccentric load as the diaphragm moves down and basically pressurizes that air against it. So that's a great position. What that's also doing is usually going to take the lower lumbar spine into flexion, which would 9 times out of 10 be the exact opposite position that we're going to experience. Just think of a woman that's pregnant or a man with a big old belly. It's pulling them forward in space. Let's get into that deep squat and try to reverse a little bit of that. So that's just, and these, we're just going with broad strokes. I may put some videos in the show notes of some drills I would do. But we talked about breathing there. How we breathe is very important, right? So if I'm stuck in this kind of like I'm overusing my neck and some stuff to get up off the ground, that's also going to prevail in breathing, right? And we see this secondary respiration pattern. So pelvic floor, let's get into a deep squat. Let's work on breathing. Let's say we can't get into a deep squat. That's where we go to our baby positions, right? Back to a 3-month supine position or a dead bug. Maybe I need my feet resting up on something because I don't have even enough control, right? We put somebody in a dead bug with their feet suspended. Sometimes that diastasis just pops right out at you because they don't have enough, basically enough, I don't know if we call it strength or just awareness. The ability, awareness of that area to know what we want them to do without really having to crunch down, and that's not what we're looking for. And we don't want high threshold here, right? We want low threshold, almost endurance load stability, right? So throughout the day, I'm not falling back into that kind of hyperextended position.
So you mentioned breathing, and so you didn't speak on the diaphragm. I hate to
We're going
jump
up,
ahead.
so I'm going to move up. Yeah, so we talked about pelvic floor. So talked a little bit about in that deep squat how the diaphragm moves down and pressurizes against that.
Which is directly parallel to that
Should be
floor.
parallel. So let's talk about positioning of the rib cage and things like that. So again, think of, we're just using a pregnant woman as the example so that the baby in her belly is pulling her center of gravity forward. When we do that, we tend to call that an open scissors position, which means the diaphragm would be at a greater angle away from the pelvic floor. So they create kind of a Pac-Man mouth, right? When they do that, they don't directly oppose one another. They actually create more pressure in the front of the abdomen, right? Pressure, we're pushing on that linea alba again. We have a decreased pressure in the back, which means now I'm going to have to hang on with those muscles in my back and, again, those posterior ligaments and even the disc, right? Now I'm using passive structures for stability. So diaphragm is important to, A, make sure I can get full excursion, that the diaphragm can actually move, which is hard in the later stages of pregnancy. Right? I just was reading an article, I'll have to maybe look it up, on the percent decrease in excursion from 7 to 9 months in pregnancy. I mean, it's grossly decreased, as you can imagine. You got a baby in there, so it can't do what it's supposed to do fully. But you also have the contents of the baby to stabilize you a little bit, right? But as soon as that baby's out, that's where I think that postpartum rehab should occur.
Oh, I know so many women that actually like PR back squats and stuff later on in their pregnancy.
Yeah,
just feel
it's
they
like
get
an
a little bit
internal
looser
weight
in their
belt,
hips and they get more stability.
Do you ever think
belly.
that baby's like in there, like in a squat position while the mom's
Pressing
squatting?
up on the diaphragm?
Yeah. It's like an overhead squat of the diaphragm. So now if the pelvic floor can accept a little load, right, we're not just in this constant contracted position. If the diaphragm can move adequately, we're focusing on where we're breathing. Now it's all about varying position and increasing load and tolerance over time, right? So we use developmental kinesiology and kind of that thought process in most of what we're doing, and we're not hard, fast rules of we got to go from 3 months all the way up. But laying on their back and laying on their stomach are requisites, right? We need to be able to move from those positions with somewhat competent. And then from there, it's just varying load, right? Come up onto all fours, come up onto one knee, come up onto both knees, get them up into a split stance, get them onto, one leg and, go from there. But it should only be dictated and predicated by, can you do that well enough, to not fall off? If I gave you 3 sets of 10 at home and by the third set, you're like right back into that compensation. Well, that drill's too hard, or you don't have the awareness, or I didn't explain it well enough.
So then you take the step back and you go.
And rehab really should be, when you send people home, it should be challenging, but it should almost seem too easy, right? Because now I have the opportunity, if it's a little bit in that easy realm, where I'm not super challenged, I have the ability to kind of own it, right? If I go out to the range every day to hit a golf ball and I just suck at hitting a golf ball, I'm never getting to hone the actual skill of hitting a golf ball. I'm just trying to figure out how to hit the golf ball.
That's familiar.
Yeah.
That was last week.
But that is the first step. That's what should happen in the clinic, is figure out what can they do well enough to go home and practice, right? And that may just be breathing. That may mean that they need an entire session of, myofascial work to allow that stuff to work better, right? That's a big issue too. Now, outside, do you have anything to add to the rehab part? Because it's hard to explain via a podcast how you would rehab something. So I'll put a couple videos for people that may be experiencing this, because I know there's people listening that are, because it's extremely common.
Well, I think the best approach to rehab is to try to avoid rehab. So get ahead of it. Like if you are pregnant and you're a few months in, set yourself up for success. You know that you're going to be expanding, put nicely. And if you're staying active, which we want you to stay active, set yourself up for success during that activity. So there's a few things that you can do while you're active to help minimize effect of diastasis after delivery.
And I'll add, before we're pregnant, or if we're a guy and we're not ever going to get pregnant, before or even in the early stage of pregnancy, we don't have to think just core work and breathing, right? Creating axial load, right, where weight is pushing down against me as gravity creates long axis extension through my spine, which is going to help create a better stability strategy, and that would be things like weightlifting, right? So a squat, a goblet squat, a back squat, a front squat, deadlifts, anything, an overhead lunge, things like that, where now you have to create better midline stability strategies. So when we get challenged by the baby in my stomach, if I've gained a few lbs, I have a better strategy. And it is about, I keep saying the word strategy, right? Because our body's constantly changing. So you should be able to carry a baby in your body, put on the typical 25 to 35 pounds, and not have this issue if we've created a good strategy. So it's not a strength thing. It's a strategy thing. It's how your brain accepts the variable. The variable could be pregnancy. It could be weight gain. It could be a back injury, right? And what we don't want is the strategy turns into a poor compensation, and now we have pain associated with, I'm not going to call a DRA a dysfunction. It's just a symptom, right, or a cause of something else.
I think the best strategical approach to that is to think about that alignment you're talking about, the diaphragm over the pelvic floor. So with pregnancy, like you were saying, you're going to get this increase in pressure on the front of the abdomen. You're growing forward. We start to hike back into extension. So if you're going to do things like loading through squatting and deadlifting, always be very aware of your positioning and your alignment of the diaphragm in the pelvis.
And that even people that aren't experiencing this, I'll throw this out
absolutely.
there. Just this week, this had to be a big topic. We had a coach come in and talk about it and things like that. An athlete came in here and we were going over, they had back pain, and towards the end we went over some deadlift squat stuff, and I said, show me, and it went into massive hyperextension, and then they went into their hinge. And then I was like, well, hey, let's try to change that. And they go, well, what? I'm getting my butt back. That was my my coaching cue, get your butt back in space, which they accomplished.
Not a wrong cue.
Misinterpreted, but also the strategy, right? The strategy to get your butt back started with massive anterior tilt, load up the erectors. Now they were having compression. They have back pain. So even people that are just, out there, doing CrossFit, lifting weights, running, right? Being awareness is the first thing of pelvic position. Second would be, how can you control your pelvic position, which is challenging it through cross-training and exercise, and then creating some sort of a load, right? Over time, you got to challenge it. And it shouldn't just be, I squat, right? So I squat to train for squats. Well, no, you need to train different movements in different directions and different axes. If I run and I just think about keeping my pelvis in that position as I run, I can guarantee your body's compensating or figuring out a way to almost make that more efficient, and it's just going to say, well, this is hard. Let's just go ahead and cheat here, right? Maybe I'll I don't know, decrease my hip extension because I need my pelvis tucked. Well, that's not a very helpful thing, right?
Yeah.
So don't create a problem by just thinking you're going to fix it during your activity of choice.
Yeah. Another thing I wanted to point out was for my postpartum moms, or if you're trying to heal if it's really affecting you.
Well, I don't know if we should say heal.
At some point.
So it all you're doing there is if it was a strain of a fascial tissue, we have to realize all we're doing is stiffening the fascia back up. So we found through research that fascia has contractile units as muscle. They're far more sparse and spread out. So it's a slow contraction, like days to weeks.
Okay, so I removed the word heal. Allow for reestablished stiffness through the anterior wall.
And I'm just saying that so people don't think this is a disease.
An injury.
It's not.
I gotcha. Well, while you're trying to reestablish that, if you cannot, and you mentioned this with our rehab approach, if you cannot maintain like a static load, like if you can't maintain stability during no movement at all, avoid tons of dynamic movement into that area, like fast sit-ups. Or
let's talk about sit-ups though, first of all. So I would almost venture to say that in clinics across America right now and across the world, sit-ups are in rehab protocols for diastasis recti or low back pain, right? Core strengthening. I think it's fading out. Yeah, it definitely exists. It's in those clinics that still hand out pieces of paper with exercise on them.
Okay, it's exercise number 7.
Yeah, so sit-ups for this issue are probably doing nothing more than exacerbating it, right? You're going through a bunch of flexion patterning, trying to use the rectus abdominis to pull your sternum towards your hip or your pelvis, and all you're doing is compensating with something else, right? That thing, you're literally the muscle that's doing that is at a mechanical disadvantage due to structural change, okay? Now, sit-ups overall have become somewhat demonized. I don't think inherently it's a bad movement, or if there is a bad movement at all. What we need to realize is a bunch of flexion moments on the lumbar spine can create issues. So if you have had a back issue, or if you are training your core because you are pregnant, I don't know if that's the best move for you, which a lot of OBs actually tell women not to do sit-ups. I don't know if their reasoning is... I don't know what the reasoning is, but it's a smart piece of advice, in my opinion.
Oh, it's a lot of, usually to sit up, I'm going to go kind of into a little bit of extension and force and momentum my body up. So anything that's going to take that lumbar spine or your core, I say in air quotes, it's going to take your core and go from a exaggerated extension into an exaggerated flexion is going to really test the limits of the anterior abdominal wall. So if you already have a vulnerability within the anterior abdominal wall,
it more.
Limit those movements.
And most people I see are far more dominant with their upper rectus abdominis.
Correct.
So if you looked at the upper 2 six-packs or whatever, and then their lower abdominal wall, which is going to include all of the obliques, the TVA, and the rectus abdominis, are like out to lunch.
Across the board, but especially in C-section.
And I want to point out to everybody that Sloan puts an
especially,
especially.
Listen, that's with
because it's like
exclamation
extra.
Mark. Yeah.
I make fun of her all the time for that. It's okay.
Let me drink my espresso.
But so that's the rehab side of things, right? So you start in layers. You start with easy positions, and I'm talking to the lay public. All my rehab folks know this, right? You start in easier positions. You increase varying positions with higher levels of stability needed, and then you start creating more load. Then you create dynamic movement around that. And you may have to go back down to the ground as we incorporate movements around there, right? Mm-hmm. So we think about just holding a dead bug, right? Well, eventually I want to be able to maybe move my arms or have a press in there or something. You may take somebody all the way up to their feet, and then when we start adding weight, take them back down to the floor.
Well, I also want to add in there, I had a thought, and it just went.
It may come back.
It went.
So a lot of people, we brought up the transverse abdominis and Pilates. So I just want to talk real quick about maybe some thoughts on like this belly button spine thing, right? So there's things out there that are being perpetuated now, like the thought of hypopressive breathing. If you could imagine, if you could suck your abdomen all the way in, right? What you're actually doing, and this is what hypopressive breathing practitioners or coaches or whatever you want to call them would say, is that you're actually lifting your pelvic floor, right? So they're saying the dysfunction with most people with incontinence or pelvic floor dysfunction is the pelvic floor has descended too far, and we lack the ability to keep it in a kind of somewhat semi-active lifted position. I'm air quoting lifted because that's not a very scientific term. But if you listen to what I said, and I'm basing this off research, this is not my speculation. Most people, if you put them on needle EMG, which is not a fun EMG, right, to have the muscles of your pelvic floor, you're going to see that they have a higher level of contraction at rest, right? So when we're telling somebody not to contract it, to actually maybe actively relax, that thing has a low level of activity. So the first thing would be get them to relax it, which some people actually need intravaginal pelvic floor work. Not what I do, not what I'm ever going to do. But there are practitioners out there, and that's no different than foam rolling your glute or your calf when it's super tight, right? Some input can change that function. So I think if we talk about hyperpressive breathing, we think we're sucking in the abdominal wall, right? Activating the transverse abdominis. We think we have the pelvic floor lifted, and now we're going to try to breathe, still with our diaphragm in that position. I'm not saying this is all bad, but just as I read an article, or maybe it was a blog post that Julie Wiebe, who's a physical therapist that specializes in pelvic floor, put up, that is not a long-term strategy for core or pelvic floor stability, right? To think that I'm going to lift my pelvic floor, create hypopressive, if you can imagine what that means, is a low-pressure system, right? I haven't pressurized the abdominal cavity. I've depressurized it. Now I'm going to use the muscles to hang on. That's what most of us are doing way too much of, in my opinion. Lumbar erectors are fired up. Rectus Abdominis is fired up. Pelvic floor is fired up. We're hanging on for dear life. What we actually need to do is be able to breathe better, let everything accept a little bit of a load, create an eccentric contraction. And then when I need those muscles to turn on, they can fully contract, fully turn back off, right? Because I can tell you one thing for sure, posture is not a function of a muscle staying on 100% of the time. But that's what posture turns into when you have an injury, compensation, positional deficiency, something like that. So I think we beat the rehab horse to death there. Mm-hmm. The other option is surgery.
Yeah, and there's some that are so extensively widened.
When some go into, so my sister just had a surgery where this went into, she had a diastasis recti, but it went into an umbilical hernia. There were all the issues that we've talked about, but it was probably not beyond rehab, but it's just like somebody with back pain, right? I've seen a couple patients where their back pain is so great, whether it was tied to pathology or not, where the pain interfered with the ability to rehab, even with things like injections or pain medication, to the point where you have to make the decision as you, as the patient, the person experiencing this, do I have the patience to live with this amount of pain or dysfunction long enough to rehab it? And some people it's not, and there's nothing wrong with that. No. It's no different than somebody that needs a knee replacement or hip replacement. Some people hit their limit or threshold where you could probably rehab them if you had enough time. Time's a huge component, but their quality of life is so changed by this that surgery is not a bad strategy. What usually does not happen is fantastic rehab or physical therapy after these surgeries. We think, hey, I sewed it up, right? So they basically go in and they sew your rectus abdominis back together, right? So we didn't actually create any stiffness in the linea alba. It's impossible to do that as far as with our techniques right now from a injection or surgical standpoint. So I've made it mechanically more advantageous to use your rectus abdominis, but have I actually trained you to do anything different than you did before? No. And that's just like somebody who has a pregnancy or a discectomy, right? We don't have great rehab over these things when we think of them as minor traumas when they're really not.
Well, I think they're almost set up without rehab on the back end of it. I think they're almost set up for more potential issue down the road. Yeah. It's marked trauma on that area, no matter what's sutured together now.
Yeah. When you've been compensating for who knows how long, right? And and this is what I tell people all the time. If you're if somebody comes into the clinic and they have, let's say they come in for ankle pain, and I know I'll give you both sides of the argument here. They come in for ankle pain, and we're doing some tests, and we say, oh, you have a diastasis recti. That is that's a finding, right? Is it correlated or not? Well, you'd say, oh, they may have ankle pain because they have central instability issues. True. But what I would not say is that we have to fix that diastasis to fix their ankle. Mm-hmm. And I think we get caught up in some of that stuff sometimes. So it's just like anything. If the compensation isn't causing pain, I don't know if we should label it dysfunctional, right? You're compensating really well. That may reach its time and point where it's not going to work anymore. But that's where I try to educate people that, hey, I know you got told that you walk weird. Do you hurt? Well, no, that's how you walk. Now, if you start having problems, we may need to change it. Right? It's just something different. That's what a lot of rehab is. It's just varied movement, or it's different. So surgery is an option. Those are really only two options with this thing. Mm-hmm. Rehab, surgery, right? Or don't get there in the first place. Like Sloan said, train yourself appropriately. Mm-hmm. And it's not like this thing's lurking in the background and everybody's going to get it if they don't train right in rehab. It's just Some people are more disposed to it. We saw some populations are more predisposed to it. But, you know, if you're thinking about having kids, probably, you know, try to get ahead of it.
Well, I like to kind of leave this with my postpartum moms is they grew a baby. After you give birth, you grew a baby. You grew a human being. Show yourself a little grace. Forgive yourself for not being super active. Don't rush back into, you know, high intense activity. Rehab yourself appropriately. That gets you back to a functional core positioning. Especially, this is very important if you're wanting multiple pregnancies.
Yeah.
Especially close pregnancies together.
Mm-hmm.
So that rehab, we can't hit that hard enough. I think every mom needs rehab after pregnancy. I think that's one of the biggest disservices that we do to our moms here in the States is we send them home. We say, hey, don't lift anything too heavy. Here's a newborn. Take care of it.
Yeah.
So I think if you are a mother, even if you don't have a huge noticeable diastasis, take advantage of some good rehab after postpartum, after delivery.
Or just work out smart. Don't think of it as, I don't want to say rehab. I want to say there should be workouts for moms after pregnancy. You don't have an issue, right? You didn't come out of pregnancy with pain. So we tie, and I'm just saying for semantics because most people do not want to do rehab. Most moms after pregnancy want to exercise, to lose weight, but in order to lose weight, you have to be able to, or get back to your fitness level, you have to be able to move appropriately. And if I run into an issue right down the road, so what I just want, again, I know it's semantics, but I'm using the semantics to encourage people. So I don't want them to think rehab. I want to think how you exercise may lead to an issue or could prevent an issue.
Fair enough.
If after pregnancy, if I get I need my core and I do 100 sit-ups a day, that may not be the best thing.
Yeah,
so I'm just saying exercise choice is a huge deal.
I got you. It's not a matter of just building muscle back.
Not at all. And that's what we're usually coaching people out of in here. Mm-hmm. Right? I stink at this. I'm going to work at it this way. Well, hey, we have to actually change how you think about it, and now you are actually going to fix yourself.
Okay, so I remove my word rehab, strategic exercise.
Ooh, that's a good one. Yeah, I like that. Well, I think we have covered quite a bit on that. Like I said, there's a lot of resources out there. I think some are better than others. Hopefully this is a good bit of information for anybody that's listening. I really appreciate the question from Michelle. Like I said, keep sending those in. You can send me a video. You can send me a DM. You can put it on a pigeon or a raven if you're a, Game of Thrones fan.
What is that called? Carrier pigeon?
Yeah, we got a little cage system. Mike Tyson runs it. He's on our roof right now. I appreciate you guys listening. You got anything you want to leave with?
No, I think we about covered everything.
All right, we're out of here, guys. See ya.
Bye.